Good morning. So I'm Priyam Gupta, and today I will be presenting a paper which is titled "To Evaluate the Visual Outcomes in Patients with Corneal Ectasia After Cataract Surgery." So corneal ectasia is a progressive thinning and bulging of the corneal structures, and different phenotypes have been recognized, which include keratoconus, keratoglobus, and pellucid marginal degeneration. In-house studies have shown that the prevalence of keratoconus in the Indian population is around 0.6%, and that of PMCD is around 0.03%. It has also been seen that over the years, the population of the world over 60 is nearly doubling. Hence, the population with cataracts is also increasing. Surgeons will encounter a growing population of eyes with pre-existing corneal ectasia requiring cataract surgery. I'm sorry, this is not moving forward. Yeah. So the challenges what we face include, we have to wait for stabilization of the disease, difficulty in obtaining accurate biometry values, decision regarding IOL selection, modifications in the surgical technique, and it's very important to counsel the patient to have realistic post-operative visual expectations. In biometry, some of the challenges we face is an altered PA ratio, tear film irregularities, a longer axial length and deeper AC, and variability in the axial measurements. Intraoperatively, there can be instability of the corneal incisions and difficulty while visualization intraoperatively. And post-operatively, there can be more hyperopic refractive surprises which can be encountered. So the purpose of our study was to evaluate the visual outcomes after cataract surgery in patients with corneal ectasia. So this was a retrospective study which was done between 2016 to 2023, and 54 eyes of 48 patients were included. So from the EMR, we got the data regarding the target refraction, and at 6 weeks, we saw the BCVA, from which we were able to calculate the median absolute prediction error. So 32 eyes in our study had keratoconus, 14 had PMCD, 4 had keratoglobus, and 4 had TMCD. The mean age of the population was 51 years. Majority were males. Majority had right eye infliction, and nuclear sclerosis was the most common type of cataract. So 80% of the cases were implanted with a non-toric IOL, and surgeons preferred the Barrett formula followed by the SRKT. When we see the mild group, all these formulas did equally well, but when we see the moderate group of keratoconus especially, Barrett did slightly better, and in the severe group it was the cane. When we look at the BCVA, we see that in the keratoconus group, the severe as well as the moderate group showed a significant statistical improvement in the vision post-operative. But the prediction error was higher in the severe group when compared to the mild and the moderate. Again, the non-toric and the toric groups did well in terms of statistical significant improvement in the BCVA. However, there were higher prediction errors in the non-toric when compared to the toric group. When we look at PMCD, again, we see that there is a statistical improvement in the vision post-operatively, but the prediction errors were again higher in the non-toric group when compared to the toric group. And lastly, we see in the keratoglobus group, there was not a very statistically significant improvement in the vision. And again, prediction errors were higher in the keratoglobus group when compared to the other ectasias. So previous studies have shown that if you have severe keratoconus, it is better to use a higher myopic refractive target. In mild and moderate cases, pentacam does better than optical biometers, and in severe cases, we can use standard K values. Some of the formulas which I have described to give accurate results are the SRKT and the Barrett formula, but again in severe keratoconus, none of them are very accurate. Toric IOLs can be used when the central 3 mm on corneal topography has a regular bow tie pattern. There is a stable astigmatism, and patients do not require or are not dependent on the rigid contact lenses. Peripheral ectasias do well because there is better regularity of the cornea centrally, and these values are more reliable and repeatable. The limitations of our study was that this was a retrospective study where again there was a lot of different IOL models being used, and there were practice pattern amongst surgeons differed. There were economical issues where patients who were eligible for toric could not opt for the same, and it was a shorter follow-up. The conclusion is that mild and moderate KC, mild PMCD and TMCD give good postoperative results. Toric IOL is suitable in mild KC and PMCD, but unpredictable results can be expected in severe keratoconus and keratoglobus. Thank you.